Okay, hi, so I'm Kat Urban, I'm a palliative care specialist, and what a vexatious topic to talk about before lunch. Obviously being a palliative care specialist, we use a lot of pharmacological management for cancer pain, but palliative care, traditionally or back in the day, it used to really be around end-of-life management, and I think palliative care have done a lot of great advocacy work around the world around opioids. I'm going to talk about opioids, to try to make opioids available to patients because, we know that they are part of our cancer pain armamentarium. And I think we've had this push to use opioids to overcome opioid fears. I still see more opioid phobia and fear than overuse. But then at the same time, we're also seeing this epidemic of opioid problems. The United States experience, as Tim touched on, there's a lot of misuse, there's a lot of deaths related to opioids, and there's the chronic pain experience where we're seeing that actually opioids maybe don't really work very well for some of these chronic pain syndromes. And so I think there's starting to be a bit of a paradigm shift, where palliative care and chronic pain are coming together, hopefully. But I think we also need to be careful that I think we look at cancer pain as a distinct identity. But of course our cancer patients are living longer. Some of their pain may not be cancer pain. They might have post-surgical pain, or they might have other chronic pain syndromes. And so, where does that really leave us? So I am going to talk about sort of pharmacological management. But I guess, I think I will talk about opioids, but I think maybe we're at a place where we're sort of moving more towards an understanding that there's a bit of a spectrum in how we treat our patients, and that actually patients who are living longer maybe need a slightly different approach. And all the non-pharmacological things that have been discussed are coming more and more into play. So I'm going to talk a little bit about cancer pain and chronic pain. I will talk about opioids, adjuvants as well, and novel agents. I really wish that I could say, here's this new great target, this agent that's not an opioid that's great for pain. And I think, unfortunately, whilst there's lots of things in development, we don't have anything like that at the moment. But, it is interesting that cancer treatment has been transformed. We've had so many new therapies. Patients are living longer. It's a chronic illness for a lot of people. But ironically, in a way, this sometimes makes managing their symptoms harder, because we have got patients living longer. We are concerned about the use of opioids and other drugs that have side effects, but they still have symptoms, they still have pain. And so what do we do with them? The causes are varied and complex, and it's not just a physical component. We all know that. We've all seen that. I think something that Michael said earlier that really got me was, that in chronic pain, we can't fix people's pain. So we're not saying to patients, right, I'm going to give you zero pain. Your goal is zero pain. And that really struck me, because I was asked to give a talk to GPs through PEPA, which is a palliative, sort of a collaborative where they help people experience a palliative approach. And they gave me slides to present. And one of the slides about cancer pain was, the goal is the patient is pain-free. And I had to change that, because I don't agree with this. I don't think, if we're saying to our patients, you are going to be pain-free with this drug, I think that's a lie for most people. And I also think it's unrealistic to say that. It's not a realistic goal to say you will have no pain. Patients very rarely will experience that. And if we do make them pain-free, we're probably going to make them unconscious or have such toxicity that they're not able to function. So I think we need to carefully consider that, and actually education is a huge component of that. And the way we talk to patients about what actually are we trying to achieve with this drug? And is a pain score of 0 the goal, or is the goal that you can be functional? And I think palliative care, sometimes we need to sort of shift more towards looking at those other goals. I mean, obviously pain scores are really important for monitoring things, but it's not the be-all and end-all. And I think also in palliative care, especially, we want to fix the problem. We want to be able to say, here's this thing that's going to make it better, and I think we just need to be a little bit careful in how we approach that. This is one of my favourite cartoons, because it sort of illustrates that patients are living longer, and all these treatments are there to make you live longer, but are we also making sure that there's quality during that time? And I think, it's a very vexed topic. So I'm just going to briefly present this patient. So David's a 68-year-old man. He's had metastatic non-small cell lung cancer for a long time, for 2 years. So he's survived longer than a lot of people. He had mets to lymph nodes and bones at diagnosis, and he continues to smoke. He had some chemo, and he actually had a really good response with reduction in his cancer. However, he developed incredibly severe peripheral neuropathy. It was really, really painful. So they had to stop the chemotherapy because of this, not because of a non-response. But he was well enough at this time, living independently, to be considered for second-line treatment. Unfortunately, while this was sort of taking place, he got admitted to hospital. He'd had a fall, and he had terrible pain, and he couldn't manage at home. And so at this time, at this admission, he was referred to palliative care. He's got cancer. We may not be able to treat him any longer. He's also got a painful syndrome. He actually had two pains. He had this, what he described as his most significant pain was this burning, constant pain in his hands and his feet. Couldn't sleep at night, couldn't have the sheets touching his feet. He also had some pain in his posterior ribs where he had a known metastasis. Even though this was more intense, 7 out of 10, he felt this was his lesser pain because it was intermittent and he could get around it, whereas the neuropathic pain he couldn't manage. He'd seen his GP who'd started him on a fentanyl patch, 12 micrograms, I'm not sure how, but and had up-titrated that, and then had also added in some Lyrica when the fentanyl was ineffective. So we'll come back to data in a minute, but I guess, this is just illustrating, and I'm sorry I don't have nociplastic on there because that was a new term to me, but I think is really, really interesting. But, there's lots and lots of reasons that our patients have pain, and I think the reason that I've put this up there is that it is really important to know what is causing the pain. I work in the community setting, and a lot of times patients are referred and GPs have started pain management without necessarily understanding that patients might have multiple pains. They potentially might have a painful diabetic peripheral neuropathy that predated their cancer, and that might be the patient's worst pain, but actually here we are using opioids because now they have cancer and we're not really kind of working out what actually is exactly going on. And obviously, what is the cause of the pain is going to impact massively on how we manage it. So pain caused by progressive aggressive cancer, we're going to manage that differently to pain caused by a chronic non-cancer condition in a patient with cancer, if that makes sense. So like, for example, someone who's got post-surgery neuropathic pain is unlikely to benefit from opioids. But if, that's different to someone who's got an aggressive invasive breast cancer with chest wall invasion and bone invasion, they might benefit from opioids. So I think it's really important to know what we're actually dealing with. And, as we've talked about already today, opioids do have a harm. That there is a risk of harm, and I'll talk a little bit about that too. I think cancer pain is different to chronic pain because I think actually there's evidence now showing that cancer itself is painful. Cancer cells, they secrete a lot of things. We know they cause things like anorexia, cachexia syndrome due to cytokine storm. Some cancers secrete something called nerve growth factor, like squamous cell cancers. This sort of stimulates bone nociceptors. They can cause nerve sprouting. So, maybe cancer itself, and sometimes a cancer, when it goes from benign to malignant, there's some evidence that that's a time when it actually becomes more painful. So cancer pain probably is quite a different entity to other types of chronic pain. And I'm just going to talk a bit about bone pain because, we used to treat bone pain with opioids, but I think we're now recognizing that actually bone pain isn't just cancer eating the bone, it's via rank ligand and osteoclast activation, and that actually, probably this is actually a neuropathic type of pain syndrome. And, we didn't used to use adjuvants in bone pain, whereas we're using them more and more now, recognizing that perhaps opioids alone are not the answer. There are still lots and lots of barriers to pain management, and as we've seen a bit of a disheartening figures of how common cancer pain still is, and actually probably we don't do that well at managing it. And I think unfortunately this is an area where not a lot has changed. I think there is still a lack of knowledge about assessment, and also a fear about how am I going to address this pain if I do find it, I don't necessarily know what to do. And also often, busy clinicians, oncologists or other teams might feel that they don't have time for the cancer pain as well as managing the other things, the chemotoxicity, the scans, all those things. And I think, I work at Concord, and certainly in our patient population, there are a lot of, community attitudes to medications in general and opioids in specific. We have a really hard time convincing people sometimes to take opioids because they are terrified. They've seen in the news, there's huge risk of harm. I'm going to become an addict. Morphine means I'm dying. This is, the end of my life. And, this person might still have months or longer to live, but they're really, really reluctant. But at the same time, they're not able to function in their roles because their pain is so severe. And I think, that's very difficult because overcoming that, but at the same time, not contributing to overprescribing in the opioid epidemic. And I think one thing that I'm not sure if it was Tim, but, we talked about misuse, that actually by misuse, I don't mean patients who are abusing their opioids. They're not necessarily opioid dependent. By misuse, I simply mean that people don't take their drugs the way they're prescribed. And it's so common. How many of us would have seen patients who are taking, say, Targin PRN, or Lyrica PRN? And I think actually there's, the way that we prescribe these drugs and how we educate people, how they store the drugs, what they do with the left, all those things are really, really important if we're going to make it a safer practice. And we are going to use opioids. So I think it really is very important that when we're prescribing these drugs, we're aware of all of these things and we educate patients appropriately. And we talk about the side effects and we talk about the risks. And that we continue to reassess our patients to make sure that what we're doing is actually working, And I think having a holistic management plan as well, and thinking not just the opioids, what are the drugs might we need? What is this pain actually being caused by? And we've talked a bit already about the opioid epidemic, and there's not just the risk potentially of overdose or diversion or someone accidentally taking the drug that belongs to a patient. But, there's sort of some thinking that long-term opioid therapy has endocrine or immunological effects as well. And some of these cancer patients, someone with a newly metastatic prostate cancer to bone could be living 3, 5, many years. Myeloma, the average survival now, they tell me, is 7 years. So, having said that, back to opioids, they still remain the cornerstone of cancer pain management. And obviously there's lots of variability between patients. I think we see now that Targin is massively prescribed in our community. It's coming from GPs. It's a heavily marketed drug, developed originally as an anti-abuse formulation, but now, of course, being touted as the answer to constipation. But actually, people don't necessarily understand how this drug works. They don't necessarily understand that the naloxone component can be systemically absorbed. I've seen patients who have not had significant liver impairment who have become narcotized when swapped to an equivalent dose of another opioid. And I think the understanding of that in the community is not necessarily great. But Targin is an easy drug. It's marketed a lot. It comes in a low dose, long acting, so that's great. 2.5/1.25 milligrams. What's that really going to do? But so GPs are using it more, and patients don't really understand. And a lot of patients don't understand that their oxycodone is an opioid. They don't understand that. They don't understand that Panadine Forte is an opioid. So there's a real lack of understanding amongst patients to what they're taking. And it might be easier to prescribe endone than morphine because it's not morphine, therefore we don't have to deal with the questions and the worries and the fears. But actually, I think we have to deal with those things if we're going to give these drugs. Otherwise, it is dangerous. Obviously, the choice is going to be dependent on patient factors. Most of us are comfortable using morphine. It's been around forever. There's lots of routes. We can give it orally. We can give it subcut. We can give it intravenously. And we know the dosing. We know the risks. So it is still a good drug to use. But obviously, we're so fortunate in Australia to have so many different opioids. And so if we do have patients with renal impairment, perhaps we might be fortunate enough that we have access to drugs like hydromorphone or fentanyl or buprenorphine or even methadone, which can be a really good alternative. Again, with liver dysfunction, we need to have consider whether perhaps hydromorphone might be safer. And then route of administration, and especially in palliative care, becomes common. But also, perhaps patients undergoing surgery for a bowel obstruction with an ovarian cancer may not the oral route may not be the most appropriate. We've got transdermal preparations. Inter-patient variability, we don't really fully understand why, whether it's to do with genetic polymorphisms, different metabolism or excretion, but we know that patients do differ, and hopefully one day we'll have enough personalised medicine that we can do a test that will tell us the best opioid. But at the moment, often it is a bit of trial and error. I guess I just want to talk a little bit about chronic cancer pain, and in my mind, I guess there's sort of two different entities here that can get lumped under this. So there's a patient who has had cancer or who has controlled cancer as a survivor who has a chronic non-cancer pain, and that's quite different, I think, to patients who have cancer-related pain but then have some treatment for the cancer and then live a long time but still have some degree of cancer pain, which perhaps the treatment hasn't been able to completely get rid of. But we know that actually a lot of cancer treatments can help with pain of the cancer as well if the cancer responds. And I think the most important thing for me here is in palliative care, I think sometimes there's a temptation of you're doing really well, your treatment's working, you're really functional, I've got you on this treatment regime, your pain's well controlled, I don't need to see you that often. But I actually think those patients are ones we need to monitor really carefully. Could we wean the opioid? When I first started palliative care, we didn't wean opioids much, and I guess our patients tended to get worse, not better, but I think we need to think, actually, you're doing okay. Is it okay just to not rock the boat? Or could we try giving you a bit less? making sure that we have considered our adjuvants, that we've considered them early, that if we're having to escalate opioid doses, we have a think, actually, is this pain really opioid responsive enough, or could we use an adjuvant early to perhaps minimise the exposure to opioids? There's been lots of discussion around non-pharmacological methods, and I think palliative care, we've always been multidisciplinary, but we perhaps haven't always been interdisciplinary. And I think, as Tim mentioned, collaboration between palliative care and pain specialists and interventions, often there has been that lack. And sometimes it's, we think, oh, but the patient's going to die too soon or it's too invasive. But I think we need to change our thinking around that. And again, monitoring for misuse. And by this I mean, does the patient really understand what it is, how to use it appropriately, what side effects to look out for, how to store the drug, all those things. And I guess, in my mind, and there's not really sort of evidence to show this, but I think sometimes for patients where perhaps we're thinking it is a more chronic type pain, maybe thinking about using some opioids where the potential for harm might be a bit less, maybe things that are like a partial agonist like buprenorphine, or there are some new drugs like tapentadol, which is a weak mu receptor, and I'll talk about it a bit more in a minute, that maybe we will move more towards these drugs in patients who we think are going to have, a longer life expectancy. I don't know. I guess the other thing is, a lot of evidence from the United States experience with the opioid epidemic and the harms is that they sort of have a trigger point of around 90 milligrams a day of morphine equivalent, where people start to think, okay, is this okay? Because we know that the higher doses patients are on, the higher the risk of harm. And maybe we need to have a bit of a trigger if we're getting up to those doses. Have a think, like, what else could we be doing? Is this really the right thing to keep pushing this drug at this time? Obviously, opioid rotation is a common practice in palliative care. There's lots of reasons to do it. Maybe the pain relief isn't sufficient with escalating doses, or perhaps patients have significant toxicity but inadequate analgesia. Patients' clinical status might change. There might be drug interactions, maybe long QT syndrome, things like that. And also drug availability. Recently in New South Wales we didn't have oral hydromorphone liquid, and that caused a lot of dramas and issues. The evidence for the practice isn't great. There's sort of, case reports or kind of open label studies where it seems that it is an effective practice. One of the big concerns for me with opioid rotation, of course, is the equianalgesic table. And there are lots of them. They're different. How do we know? And so I guess I think that, it's important to have an idea of the relative strengths of opioids, but a lot of these tables were developed on a single dose study in a healthy patient. So that's quite difficult to perhaps extrapolate to an unwell person with organ failure. And so I think, obviously, it's a guide. It's good to have an idea that perhaps hydromorphone might be a lot stronger than morphine. But I think it always comes back to individual patient. You have to look at the patient factors. Is this a frail elderly person? Have they already got signs of toxicity? Have they got organ failure? And my attitude is always to look, yes, I can work out the rough guide, but dose reduced. You can always give more, but it's hard to give less. So 25 to even 50% dose reduction may not be inappropriate to begin with. As long as patients understand, I'm changing you to this. Look, the next 24 hours your pain might get a bit more out of control. Let's use the breakthroughs, keep track of what's happening to allow us to know where to go from here. So back to David. So he came in, he had these two pains, really debilitating him, and so the fentanyl patch was removed. No one was sure if it was doing anything for him, and he was converted to subcutaneous morphine at what was considered a roughly equivalent dose, although seems a bit high. His Lyrica was up-titrated, and actually, just with those changes, his pain was much better, almost overnight. So obviously it was someone who responded better to morphine than fentanyl. Was that because he's a bit cachectic and he doesn't have adipose tissue? I don't know. But anyway, morphine worked better for him. And he also then, once his pain was a bit better and he was able to go across to another hospital for radiation, he had a single fraction to his rib lesion. And then the plan was, look, let's go home. You're doing well. You're walking around. He was converted to oral MS-Contin at an equivalent dose and some Ordein, continued on the Lyrica and went home with the plan to start second-line treatment with Alimta. So I'll come back to David again in a minute. So look, what's new in opioids? Not a lot, really. You would have all heard of Actiq, which is the fentanyl lozenge. It's been around for a long time, the one that looks like a lollipop. There's a couple of other preparations that are a bit newer, Abstral and Fentora, which are similar. They're both a sort of immediately dissolving fentanyl buccal preparation. The Abstral they recommend sublingual. The Fentora, you can supposedly put it anywhere, really, as long as it's in contact with the buccal membrane. Fentora, they think, lasts a little bit longer, so maybe to 3 hours as opposed to 1-2 hours. And I guess the main place for these drugs has been they've been promoted for incident pain. So because, the nature of incident pain is it comes on quickly, so within minutes, and it lasts a short time and then it's relieved. And so the thinking is your traditional breakthroughs with your short-acting opioids, morphine, endone, whatever is, they can take half an hour to work, by which point the cancer pain perhaps has peaked. They're having a peak 2 hours later, by which the pain episode may be finished. So these drugs were sort of developed as maybe to mimic the cancer pain kind of time frame a bit more accurately. However, when you look at the the effectiveness, this one study looked at them and what they found that, fentanyl sublingual was superior to morphine for the treatment of incident pain, but the numbers needed to treat were between 12 and 18. So their recommendation was, look, still try your usual opioid first, but then if that's really not effective for this patient, perhaps these drugs can be beneficial. The other tricky thing with these medicines, two things. One, you need to be on at least 60 milligrams of morphine equivalent per day is what they recommend. And obviously the risk there is 100 micrograms of fentanyl is quite a lot of fentanyl. If you absorb all of that in an opioid-naive patient, it's a potentially significant risk of overdose. And the other thing is that the titration can be a little bit tricky. So usually if you're using a breakthrough, you go to between 1/6 or 1/12 of your opioid dose and you get the patient to use that. With these drugs, you have to individually titrate for every single patient, regardless of how much everything else they're on. So you always start with the lowest dose is 100 micrograms. If in half an hour they still have pain, they have another 100, and that's one titration episode. Then you have to wait for Abstral 2 hours, for Fentora 4 hours, before you can use the drug again. The second time you can still try the 100 and then add another 100 if it doesn't work, or you can say 100 was ineffective and go to the next dose. And then you can do this 4 times a day until you find an effective dose. So that's a little bit tricky, especially in a community setting or in a ward where perhaps the staff are not familiar with the use of this drug. And then tapentadol I sort of touched on. So tapentadol is a relatively new drug. It was initially used in chronic pain, but has now got some evidence in cancer pain. And we think it's probably not inferior to oxycodone or morphine. And the reason that perhaps we think there might be an advantage in this drug is in patients who have a neuropathic component. And we know cancer pain often is very mixed. So a lot of patients probably do have a neuropathic component because this drug is still a mu opioid agonist, but it's a weak agonist there. And it also has noradrenaline reuptake inhibitor kind of activity. So the thinking is that because it works synergistically in these two ways, that perhaps the toxicity is less. My one difficulty, and I haven't used it a lot, is that the lowest immediate release tablet here in Australia is 50 milligrams, which is about 10 milligrams of oxycodone equivalent. And for some patients, that's simply too much to start with. If they're opioid naive, it's hard to begin. If they're on opioids already, perhaps it's a bit easier. But it's maybe a drug that we might start to see a bit more and more. It does have a sort of a ceiling dose at the moment. Whether that will change, I don't know, which is 500 milligrams per day. So I'm going to touch on adjuvants. Look, I think non-steroidals often get overlooked in cancer pain. And obviously there are risks of harm, bleeding, gastric, renal issues, cardiac issues for some. But I still think that these are drugs, perhaps, if we use them in a short-term way in a patient who can tolerate them, that we shouldn't forget about. And especially bone pain. Say you've got someone who is going to have some radiation or other treatment that's going to help. Maybe this can be a bridge to help get them through that time period until their cancer treatment can be effective. Obviously Panadol, we all use it. Everyone now realises that the higher opioid doses that it seems to be effective when patients are on smaller doses of background opioids and perhaps less effective once they're on big doses. Steroids, we know if it's a patient's got headaches from brain metastases with edema or cord compression, that these drugs can be really, really useful. Whether they're useful for just any kind of cancer pain syndrome is debatable. Obviously, the gabapentinoids are everywhere now. Lyrica is on the PBS for neuropathic pain and cancer, and it's very commonly used drugs. The numbers needed to treat 4 to 6, not too bad. Gabapentin we're using less because it is now a private script, and also because of its non-linear pharmacokinetics, the titration is a little bit more tricky. In the literature, I've seen that Lyrica is sort of 6 times stronger. There's this 6 times conversion. I think I'm very cautious about that, and I'd be very careful about sort of just simply, if you wanted to change someone, just using that kind of factor. But that's what I've seen in the literature. Obviously, TCA's been around for a really long time. One advantage, perhaps, is that they're not renally excreted, so if patients have renal impairment with the gabapentinoids, we have to be very careful with dosing. With TCA's, less so. the thing to remember is, we do use them for sleep and mood as well, but 10 milligrams of amitriptyline is not going to do anything for depression. With amitriptyline, you need 50, 75, 100 milligrams for mood. So I think we just need to be a little bit careful when we're sort of using one drug for multiple problems, that we don't underdose patients for their depression, thinking that, we're killing two birds with one stone. Well, my patients have told me not to say that. They don't like the idea of killing birds. Obviously, the risk with TCAs is delirium, postural hypertension, and their contraindication in cardiac, with patients who have cardiac issues. Lignocaine, I think lignocaine is becoming perhaps more researched and more investigated. It's a sodium channel blocker, and the thinking is that it can be helpful in neuropathic pain, neuropathic cancer pain. Neurologists have been using it for a long time for various syndromes like cluster headaches. They give it intravenously, and they monitor the patients. There's a study that shows that actually intravenous use, and they did, I think it was 5 milligrams per kilo over 1 hour intravenously in palliative care cancer pain. And they found that they didn't have any adverse cardiac effects. So the thinking is perhaps we don't need to monitor these patients. And we know that also it's been used in a subcutaneous infusion way, where the dose ranges are somewhere between 0.5 to 1.5 milligrams per kilogram per hour. And on average in this study, the infusions lasted about 5.5 days. And they actually found that, I think 68% of the episodes patient experienced a reduction in pain score over 2, and they were able to reduce their opioid doses. So I think it's a drug that we should consider. Again, hard to use in the community, but in the inpatient setting, perhaps we could be utilising these drugs more. Ketamine has a bad rep. This was a seminal paper in 2012, where they looked at a palliative advanced cancer population, and they looked at ketamine infusions, and really that there was no benefit in pain, and actually patients had a lot more toxicity. I guess, does that